This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, October 14, 2024. I'm Len Sierra. I'll be moderating tonight with a little help from my fellow moderators and all of the attendees here. And we're going to start with a new member, Frank Chambra. I'll just grab my question sheet here. Okay, so Frank, how old are you?
I'll be 65 Friday.
No, happy birthday.
Happy birthday.
Thank you.
And where do you live, Frank? You're in Ohio, right?
Yeah, Westerville, Ohio. I'm originally from New York.
Oh, yeah, we're in New York.
I grew up in Long Island, but I mean, I was, basically a city guy.
Yeah, okay.
I
And
just said that because the other guy said he was from Brooklyn. It's all right.
oh yeah, we've got Brooklyn, we've got the Bronx, we've got Queens. We're well represented here in New York.
Yeah, well,
Live in Cleveland.
very cool.
All right. And I assume Rick already knows how you heard about AnCan, so we don't need to.
No, I don't. I have no
Oh, you
idea.
do? Oh, okay. So
We
tell
didn't-
us, Frank.
we-
My wife found it on the internet.
Okay.
So
Okay.
we just got interested and we looked it up and came on last week and listened and everything sounded really great. So I thought, try to join in.
Yeah, you came to the right place.
I think so.
So, Frank, what was how old were you when you were diagnosed, and what was your Gleason score?
So I was diagnosed in 2018. How old was I? 58. My Gleason score at that time from a biopsy was a 7.
Okay, but did it change?
Yes. Oh
You
yeah,
had it.
they did a total took prostatectomy,
Right.
a total prostatectomy, and my Gleason score was then a 9.
9. Wow, what a big change.
4 plus 5 and 1 plus with a lymph node.
1 positive lymph node in the pelvic region?
Yes, sir.
Yeah. Any seminal vesicle invasion?
No.
Okay. So what was your PSA at that time?
6.
Okay. So they, when they did the prostatectomy, did they use a wide margin, or did they radiate the whole pelvic region, or just the prostate?
Yeah, so they took the prostate out, obviously, and all my margins were clear, and then they did radiation on my pelvic area, like later on,
Okay. What
3
type of
months
radiation?
later.
3 months. What type of radiation?
What type of radiation, honey? Salvage radiation to my pelvis.
Right.
The beam, I don't know how to call it.
IMRT,
Yes,
probably. Yeah.
yes, sir.
And so they did the salvage radiation because you had a post-surgical PSA that wasn't 0. Is that it?
They decided to do the salvage radiation because they said he had the 1 positive lymph nodes, but everything else was clean. They did an Axeman scan and they just decided to just go ahead and give it a try to see if that would help, just do the salvage radiation.
We can't. Your wife has to get closer. She's very garbled.
I have to get closer.
She can come on
And
camera.
I'm not the sharpest tack in the shop. You know what I mean? So that's why I
Right.
need my wife.
Okay.
Can you hear me? So
Hello.
when he had the positive lymph node, the doctors decided afterwards that they should go ahead and do the salvage radiation regardless. Back at that time, there wasn't a PSMA PET scan, so they did an Axeman scan before they did the radiation, and they saw no cancer anywhere, so they just went ahead and just go ahead and do the radiation.
Well, they saw the cancer in the one lymph node, though, right?
Well,
Right,
I
at
think they may.
surgery. Yes,
Yeah, they found that in surgery, Len.
surgery. Yeah.
Oh, and they removed it in surgery?
Yes. Yes.
Oh,
One of
okay.
8 lymph nodes. Yeah.
Oh, okay.
So they found the lymph node in surgery. Then they did an Axeman scan, but they didn't find anything else. And then they went forward with salvage radiation IMRT.
Radiation.
Okay.
Yeah.
Good, they got the
So,
only node there was.
Yes. One node. That was it.
hmm. Did they do a PSA before the salvage radiation?
Um, yes, it was, let's see, his PSA was 0.5, I think, at that time.
Ah,
His
so
PSA
obviously there
came
was
down, yes.
something else going on there besides that one lymph node which they removed.
Right, and there had to be because now it's spread everywhere years later,
And
but
so,
that's all
which,
they,
which doctor are you using? Do you first let me ask, do you have a medical oncologist?
yes. So
And who,
we have 2 medical oncologists. Um, we see a medical oncologist through my insurance because we can't go out of network. And then we actually pay out of pocket, go to the high state, to the James, and see a genitourinary oncologist there.
and who is that one? The GU oncologist?
Yeah, his name's Dr. Yang. He's from the Ohio State University, the James Cancer
Yep.
Institute.
Okay.
Yeah. Yeah. I don't know Dr. Yang, but we do know a couple of the docs at the James, Dr. Mordasavi, and then there's an African American guy who's a GU med onc there, but Yang I don't know.
I think that's Dr. Monk.
Yes, thank you.
Yeah.
Dr. Monk and
Mhm.
Dr. Moore. Yes, Dr. Monk and Dr. Mortasavi are the 2 that we know, but we don't
Yeah.
know Dr. Yang. But if he's a GU
Tried
med
to
onc,
get into, yeah, we tried to get into Dr. Monk and wouldn't happen.
okay.
So
That's because you didn't know us. If you would have known us,
exactly.
we could have used a little leverage to. Certainly, we could have gotten you into Mortasavi for sure, and maybe
Yeah,
Monk.
that would have been fantastic.
Yeah, he's probably the low guy on the totem pole, Dr. Yang. But if he's a GU
Yep.
med onc, he's working with Monk and Mortasavi, then he has access. So
Yeah, I hope so. Yeah.
So now that Frank will be 65, I guess you should try and find a insurance that will allow you to go out of network.
Well, it's because he's on Pluvicto right now. We're
Oh,
staying with my insurance until March, and then we're going to switch to Medicare, and then we can use the James at Ohio State.
very
okay.
good. Okay, so we jumped ahead there. So after the salvage radiation,
Yeah,
what
we jumped.
happened next?
Well, he went on Lupron for 2 years, and his PSA stayed like 0.03 for the 2 years on Lupron. He went off Lupron, and within maybe 8 months, his PSA went up to 78. They scanned him
Wow.
with a PET scan, PSMA PET scan. They found just a little bit of metastatic disease. They started him back on the Lupron and on Arledia, and he did well on that. His PSA came down. I think the lowest, though, it stayed was 0.34. And then last July, the PSA started climbing too, did another scan, worsening of the skeletal mets. We tried Provenge. He's had the Guardian 360. He does have the ATM gene, and then we did the Provenge, and then he had more radiation because he was having some bone pain to his ribs and sternum and spine. And then we tried Lynparza for about 3 months, and the PSA didn't come down, actually went up to about 40, went on Taxotere for 4 treatments. The PSA was 100, worsening skeletal bone mets, and now we're on Pluvicto. And we've had 1 Pluvicto. We're going to do the second one in 2 weeks.
Okay. Any PSA result after the first Pluvicto, or is it too soon?
No, we had one before his, because his PSA on chemo, the lowest it got was 100. It was up to like 190 when we started Pluvicto. So he has blood work on Monday before his next Pluvicto.
So it sounds like they cut off the docetaxel after 4 sessions because it wasn't helping. Is that right?
Right, correct.
Yeah.
Thank you for
So now
doing
you're
this.
on Pluvicto. And did they, so they did the PSMA scan, so you did have PSMA positive cells, but did they do another scan to see if there are any non-PSMA positive
You know what?
cells?
I don't think so. I don't think so. Just the
Okay,
PSMA we've had.
yeah.
Should we ask for another
What
one? Because we see the oncologist on Tuesday.
I would if it were me,
Okay.
because Pluvicto can be toxic, and if Frank has a lot of lesions that are not PSMA positive, I wouldn't waste my time with further
Okay.
Pluvicto treatments because it's not going to help.
Okay. Okay.
So I would ask for. Well, let me. Do you have any other questions for us before I open it up to the group here?
No, what scan would we ask for in particular?
In Frank's case, the FDG scan might be a good option because he
Okay.
does seem to be off to the races. So
Okay.
that might show something. FDG scan or an Axumin scan or even a CT scan, any of
Just to
those.
see if there's any, non-positive PSMA cells there.
Yeah,
Exactly. Yeah.
yeah.
Okay.
Have anybody here been as far as me and done the Pluvicto? And so obvious my question is, I mean, I'm making plans on living, um, but like here I am now tonight, I'm kind of, it's hitting home and I'm kind of scared, because this
Sure.
is serious right now.
Yeah, yeah.
So
Well,
we
certainly we've had guys who've had full treatment with Pluvicto. I don't know if there are any right here tonight. And want to raise your hand,
I
somebody?
think I think Keith Lawrence just did. Len,
Oh, yeah.
I saw
Yeah,
his hand go up for a second.
I'm pretty much right, very close to where you are, Frank. I've done 1 Pluvicto. I saw a great decrease in bone pain coming off of that Pluvicto, but my PSA has continued to increase, and slowly, but increase. So I understand where you're at, but I don't have like the full course of Pluvicto under me. And I have a lot of bone mets. So
Yeah, me too. And I only got one thing of Pluvicto too.
Shouldn't he know that
I don't have
Pluvicto
any
only
pain
works
though.
well with 1/3 of people?
Jeff Marchie, please. If you want to talk, put your hand up. Don't just
Well,
jump in.
it's
And
just
and
that
you cut him off. Please finish. Please finish, Keith.
so yeah, that I don't have a lot of long-term experience, but somebody else mentioned they have some a full course of Pluvicto.
Well, I said that We
Oh,
have had guys who've had
we've
the
had,
full
oh,
course.
gotcha.
I don't
Okay.
know that they're here tonight. Some have even done 2 courses, right, Rick?
Yeah, we've had many men, just for the benefit of Keith and the benefit of Frank. We've had many men go through Pluvicto, going back as far as 2017 when it was in trial in Australia. So we have a lot of experience with Pluvicto. We've had men who have done the alpha particle instead of the beta particle, with some success. I think Len's advice, is outstanding, which is to make sure that you get an FDG PET as well as a PSMA up front, because many of the guys that failed didn't do that, and they had lesions that weren't treatable. So I absolutely endorse that. The other thing I want to come back to, and then we'll go to the 2 hands that are up. You mentioned you got a Gardant. Was who ordered the Gardant for you? Was that your local MO, or was that the James?
So that was the urologist that our urologist
Right.
um, that that ordered the Guardian 360.
Okay, so you need. I would to add to your list for Yang. You should definitely get a liquid biopsy.
We did that too. We had that.
Who was that with?
We had the Guardian, that urologist, but Dr. Yang has all of those results from the liquid
Yeah, no,
biopsy
you
and
need
the
to.
Guardian.
No.
Okay.
Hear me through. You need to reorder. First of all, we personally don't like Garden. We don't think it's the most reliable. Secondly, things can change, especially after all this treatment. And so it's time. How long ago was that Garden study ordered? More than a year?
Oh yeah, August of 23.
Yeah, you definitely need an updated liquid biopsy. And with the PSA where it is, you should get a decent result. We would suggest it gets sent to Tempus, but it could also get sent to Foundation Medicine, either Tempus or Boston Gene. Or if they want to go with Foundation Medicine, that's fine, but he doesn't get as good information. But it's really important. What we're looking for is whether there are any of these tumor suppressor growth genes. So those are genes like P10, TP53, RB1, NBN. So we would really encourage. In fact, I'm sort of surprised that Yang didn't do that on your first trip to see him.
Nope, he didn't know. Mm-mm.
Okay, well, he should have done, given the
Okay.
time that's elapsed and the fact that you've done the Lynparza and the docetaxel. How long were you on the Lynparza, Frank?
3 months.
How did you do with it? Did you have?
I think it was a waste of time. It was horrible. Made me sick.
Yeah. Okay. Well, 2 things on that. One, it probably was a waste of time because we know it rarely responds to ATM, and we don't think the doctors, in our view, we're not docs, but Len and I have been campaigning for many years, 4 or 5 years, that it is not given to men who are on who only have ATM, because it rarely works. Um, so, secondly, we're well aware that it causes bad side effects. We got a guy at the James right now who wound up in the hospital for 2 weeks with the side effects from the from olaparib. The PARP inhibitors are tough drugs to take, and so that's sort of what I wanted to say. But if the Garden didn't show any of those genes I mentioned at that time, the RB1, the TP53 or the P10? No?
No.
No.
Okay. No. Okay. Well, things can change, and they do change. And that's why we say it needs updating, and sooner rather than later. So let them grab and let's see what comes back, because that could be an indicator. Anyway, let's go. We got Dennis Correa and then Jeff Marchi. Dennis.
I think I heard you say that you have the ATM mutation. Frank, is that correct?
Yes.
Okay, because I'm going from memory here in a couple of notes, but Pluvicto does seem to have a better response for those men
Yes.
that have the ATM mutation.
Yes. Good spot, Dennis Correa.
Well,
Very good spot.
I mean, to encourage you, this is, you do have a very serious disease here, and you have to treat it as such. And just keep finding out as much as you can about your specific situation, your specific disease, where it is, and everything else. And these mutations that Rick and Len have been talking about, but have something to look forward to, that you should, from the latest information, have a good response to Pluvicto, because it does not work for everyone. I just
Yeah.
want you to pick up on that.
Just to clarify, he said that it works better with the ATM gene.
We
That's correct.
think, yeah.
They have a better response. Men that have that gene appear
Yeah.
to have a better response to Pluvicto. There are some other gene mutations that are just the opposite, as Rick has mentioned, with TP53 and some of those, they don't have a good response if you have those. But
Yeah. But
I don't
ATM
know,
is a
Rick, if
good
you
one
want to
to have.
elaborate
Is
on
a
that.
good one.
All right. Somebody else, Jeff Markey, and then Jeff.
I mean,
Dr. Jeff.
the fact that you have ATM is a good thing, because Pluvicto only works for 1/3 of people well, 1/3 of people just okay, and 1/3 of the people not at all. So that's something people should know when they get on it, that it hasn't been that effective. When you drop Lupron, did they test you for PSA every month or 3 months to see if it was coming back? Because you seem to have gotten worse within 9 months, and weren't they testing you regularly since you were off Lupron?
Yes.
Yeah, I was being regularly checked,
And
and then the markers went up.
but they went up very, very high. It wasn't going up. I mean, after a month or two, it hadn't gone up significantly.
Once he went
Jeff,
back on, once he started back on Lupron and Eligard, his PSA stayed down for a year. But in 23 last year, when it started going up, and then it just kept going up. And yes, they were checking him every month, and that's when they decided. And I don't even know if Provenge was a good idea either, but that's what they told us to try.
Did they ever did they ever put you on abiraterone, Zytiga, or what was
No, they
lutamide,
did not. I don't.
enzalutamide,
No.
apalutamide, darolutamide?
Just that. Well, the Erlita is the one of those.
Yeah, that's apalutamide.
Okay. They did put. All right.
Yeah.
So, and that
All
did
right,
not work well for you for a long time. Is that?
It worked for almost 2 years.
Yeah, I was on it for a long time, and I tolerated that pretty good. I mean, I worked full time while I was on that stuff.
I
Dr.
just was.
Jeff, you're up.
Frank, your biopsy, did you have an intraductal cancer on your biopsy?
No,
It
no.
was just adenocarcinoma, no intraductal.
Yes, sir.
Okay, thank you.
So Len, I think that we've given we've given the Chambers a couple of items to talk to Dr. Yang about. And I think stay the course and see where you're going with the Pluvicto, and it may well work. I will tell you that in some men we see a bounce, so your PSA can go up after the initial. So don't get scared if it does go up, because that can happen. And in some men, we don't see a response until the fourth treatment. So you sort of got to stick it out and see what happens. But I also think that the ATM is a good sign. But I think that the next sequencing will be important. It'll give us some indicators.
Thank you.
Alfredo, can you mute yourself because we're getting a lot of feedback?
I think
Thank you.
the problem. Yes, he can mute. Go ahead and mute, Alfredo. Thank you. Thank you.
Rick, if I'm recalling correctly, the other unfortunate news for Frank is that when Pluvicto is used after chemo, it doesn't work nearly as well. Do you remember that from I think it was ASCO GU?
No. It's no. Well, what you're thinking of is that if you give docetaxel after Pluvicto, the docetaxel does not work as well. That's the poster, and I have that poster. That's the poster from Montreal. So what they saw was that if you use docetaxel before Pluvicto, it was more effective than if you used it after Pluvicto.
Okay.
And that poster I have. If you don't have it, send me a note and I'll ship it to you.
Yeah.
So
right.
don't worry about that one, Frank.
Excuse me?
Don't worry about
No,
that
I'm not
one.
worried.
Okay.
Thank you.
Frank?
I want to ask a question.
Yeah, go ahead.
I just out of curiosity, Keith Lawrence, how old are you?
I'm 60, Frank. And I've also been through almost exactly the same treatment path, Provenge and onto Pluvicto this
So
year.
how do you feel? I mean, I don't know if this is how I could do it, but how do you feel about, like, I'll be straight up. How do you feel about your chances right now? I'm putting it out there.
Yeah, exactly. I mean, it's I feel better than I felt in a month ago before I took the Pluvicto. So in that sense, I'm feeling better about kind of where I'm at right now. Although I got this test a couple of days back, and I'm either seeing the bounce, my PSA is continuing to go up. So that's my concern. Ultimately, I've worked through. I've also got Gleason 9. I've got innumerable bone metastasis, and that was at diagnosis. So I kind of started out worst case with a PSA over 1,000, 1,400.
Wow.
So I've pretty much adjusted my thinking that my 5-year outlook is about a 25% survival.
Yeah. I'm making
Every day
plans
I
to
get
live.
that's
I mean,
good
that's
is,
my outlook.
yeah. Every day, every good day that I get is a good day.
Yeah, I agree with that. Thank you.
Right.
I mean, I
Yeah.
don't want to pry into anybody's personal life, but these are the
No.
questions I ask myself.
Oh
So
yeah.
now that I have you here, that you're going through the same thing, I can kind of bounce that off of you and see like how do I have to adjust the way I'm thinking. So I think that just happens naturally that you do adjust the way you think, and you know you just live your best life now.
Absolutely.
So
I completely agree.
I'd
Yeah.
like to bring in Dr. John because I'm not sure, Frank, if you're aware of our Men Speaking Freely group. I know Keith is. But these are the sort of issues that are very fair game to discuss in Men Speaking Freely. And we happen to have a meeting on Thursday of this week at the same time, 8 o'clock Central, that Dr. John will be moderating. Dr. John, you want to say a few words to Frank, to Keith, and to anybody else about Men Speaking Freely?
Yeah, Frank, you're welcome to come. It's a different kind of group. Instead of talking about technical issues, treatments, and side effects and managing care, like in this meeting, that meeting is set aside to talk about feelings, emotions, fears, uh, anxiety, depression, coping, survivalship, men's psychological issues. Um, so it's 8 to 9:30, 2 Thursdays a month, and the next one is this Thursday if you'd like to come.
Rick said 8 Central, isn't it 8 Eastern?
8
8
Eastern.
Eastern,
Yeah,
Oh,
8
okay.
Eastern,
Just so they
sorry.
know.
or
Commit
Keith.
to that.
We'll send you an invitation if the system works. Okay.
All right.
And
Thank you.
if you get an invitation, it will have a little write-up with a theme, but we don't have to stick to that theme. We talk first and foremost talk about people's current feelings and issues. That the themes are only if we run out of
Yeah, I don't even
individual
have to talk. I
topics.
like to listen too.
Yeah, yeah. There's a lot of guys about that. You don't have to talk.
And
Thank you.
I'll sign you up on your, which email is this? I'll sign you up on your Hotmail address to get a reminder. It'll probably come out tomorrow or Wednesday. You'll get a reminder. It's in this same room, Frank.
All right. Thank you.
And for your wife, we do have the Care Partners group. There's one this week, and that'll be the second meeting of the month. In that second meeting of the month, we may discuss grief and bereavement. We try not to discuss it in the first meeting of the month. Just wanted to give you a heads up. And she's welcome, and that's in this room tomorrow at 5 o'clock. Are you a vet? I'm asking for Jim Marshall. Are you a vet, Frank?
No, but my son is.
Well, we have a vets group, which is fantastic, and it's led by Captain Jim Marshall, and it is not about disease specifically. It's about making sure you get the right treatments, how to get the right treatments, and how to get the most benefits that you're entitled to. Dr. John is also a moderator in that group because he spent his career at the VA. And Sylvester is a moderator in that group because he also spent his career at the VA. So we have
Very
some
good.
real expertise in that vets group, and if your son needs any help with that. The other thing is, and I was going to mention this, ask you if you had any kids. How old's your son?
46.
Has he gotten a baseline PSA test yet?
Yes.
Okay, so that's good. I'm really pleased to hear that because a lot of times it doesn't happen and he needs to watch carefully because his dad has made him high risk.
Thank you.
So So we just want to make sure that he follows it, and he follows it closely. Real important. And I think Gary Peters has his hand up, Len.
Yeah, go ahead, Gary.
Actually, what Rick just said gave me another question. Rick, should my nephews be tested because of me, or is that too far away?
Is this your sister's kids? Is that it?
Yeah.
It wouldn't hurt. I mean, I think it's probably a little further away. Are there any gene mutations? Are there any inherited gene mutations? None
Not
that you know of, huh?
Not for me.
Probably not then, but it doesn't hurt. If they get a baseline test at 40, doesn't hurt.
Okay.
Now, what was the other thing that you had?
The other question was for
Yeah.
Frank. Frank, did I understand you to you or your wife in describing your case? Did you say that during your prostatectomy they found no positive margins?
They told us all the margins were clean. That's what
Yeah, they told us all the margins were clean,
Uh,
and I
I'm
only had one lymph node.
I'm confused.
He had
they're-
clear margins, Gary. He had clear margins.
And can that still lead to a metastasis?
Well, yes, because they also took out a lymph node, and they found that even though he had clear margins, there was disease in one of the lymph nodes.
I thought that could only happen if there was a break in the margin.
Just
No.
to clarify, Gary, the margins test for local invasion, where the cancer invades through the prostate, but it can metastasize either through the lymph system or through the blood system. So in his case, the lymph system carried a metastatic cell off, and it got picked up into the lymph node and grew there. Another way of spreading is that the blood system, the blood supply to the tumor, could have picked up a metastatic cell and sent it off to the bones.
Thank you, John.
All right, Jim Marshall, go ahead.
Frank, I don't think you said that your ATM, okay, is that a germline or somatic?
That's probably a germline, I'm thinking.
No, I think
Germline. Yeah, it's germline.
it is germline. Did you confirm
Yeah.
that with something other than the Guardant test? Because Guardant gives you a somatic result. Okay, so Guardant gives you a somatic result, although it can also give you a germline result. You need to make sure. But if it came from Guardant, my guess would be it was somatic unless they confirmed. So have you ever had a germline test to see what inherited mutations you carry?
Yeah.
Frank?
Yes, I have.
You have. And did ATM show as a germline as well?
They didn't tell us that.
Okay, so you need to know your germline, what your germline mutations are, if any, because it impacts your kids.
They called you and said there wasn't.
You know, my wife is saying that they called us and said that there was none for our
Okay.
kids, for my kids.
Okay, so you don't have any germline. Then that's good. Then you don't have any germline. That's fine.
Okay, I was
No.
wrong. Thanks, Rick. Thanks, Rick, for clearing it up.
All right, Frank, any final questions for the group before we move on?
The ATM was somatic.
Right.
Yeah.
My wife just dug that out of our files. So
Yeah. Yeah. That's
I'm
what.
good. I mean, I appreciate everything you guys said tonight.
Yeah.
All right. Well, we hope to see you again next week, Frank.
Yeah,
Okay.
Keep
Thanks for
coming
coming.
back, man.
I'll be back.
Good.
Yeah.
I'm gonna hang around here. Definitely. It's been a blessing to find you guys. Thank you.
Yeah.
Sierra gets very happy. The more Italian gents he can get onto this screen, the happier he is. You know,
Nice. Yeah, I'm
All
not
especially
all
if
Italian though. That's my problem.
they,
I got some Irish
especially
and
if
Swedish in
they
there, some Greek.
sorry, say that again.
I said I got some Irish, Swedish, and Greek in me too. So, we're all mixed.
beautiful. Beautiful combination.
Yeah, I'm American, I guess.
All right. Now, before I call on our next person who wanted to speak tonight, is of those who said they want to speak, does anyone have to leave soon that I should call on you first? No. All right, then. We will go to Dr. Jack. Go ahead, Jack.
Okay. I've had a bunch of consultations with various doctors, my primary care once a year physician, my rheumatologist, my electrophysiologist. And what I've come to realize is the degree to which most physicians that I've had contact with have no awareness of the drugs that I'm on. They're totally unsophisticated when it comes to Nubeqa, Relugolix, and how it could possibly be influencing me in terms of any results that I've gotten on my blood tests or my symptoms. Starting with my rheumatologist, I went to see him, and my hands have gotten so dysfunctional. They're swollen. I can't close them. I can't grip. He sent me to physical therapy, suggested I go on NSAIDs. He has no idea why this is happening. He's speculating, but he doesn't understand that it could possibly be related to low testosterone. It could possibly be related to my tendons getting weak as a result of the muscles in the hands getting atrophied, or like sarcopenia, like the rest of my body. And my internist, who drew a bunch of blood tests on me, and my blood creatinine was 0.54. It's usually around 0.7 or 0.8. He couldn't understand why that was happening, which is abysmally low. And I had to research it and educate him and tell him that my low testosterone is causing a sarcopenia, and my muscles are shrinking, and as a result, the creatinine is very low. And I also been avoiding meat and being more of a vegetarian or pescatarian, having a lot of fish this past year, and I think it's shown up with my creatinine being as low. I'm asking you guys, have you had similar experiences with your creatinine over the years? Have you noticed that it's been low? One, and two, have your hands ever gotten swollen like sausages so you can't close them?
Well, I've never had the low creat, Jack, but I have had trigger finger. I don't know if that has anything to do with the. Yeah,
Very
you've had
much
that
so.
too.
They're all
Yeah, and
trigger
I know.
fingers.
Yeah, I know of several other guys on hormonal therapy who get that trigger finger. You have it too, Jeff Markey? Yeah. And John
Yeah,
too. Yeah, look at that. Fairly common. And you too, Rick. Okay.
no remedy other than just tincture of time and waiting it out and hoping.
Well,
No, you
what I
get it
did for the
injected.
trigger finger is instead of surgery, I went to an orthopedic doc, but instead of surgery, he said, let's first try an injection of prednisone. It's actually cortisone.
I've
And
had,
that worked.
yeah, I know. I've had that.
Yeah. Okay.
Yeah.
I've had both surgery and cortisone.
Yeah.
I think I exercised my way out of it over like a year.
Oh,
They were
yeah.
talking about that surgery, but I did a
Physical
lot
therapy.
of, yeah, I did it myself. I did a lot of like squeezing the ball and wrist
Mm,
exercises,
yeah,
elbow, shoulder, and it's been gone for number of years. But it was like a year or two of work.
it takes a while. Definitely does.
And I was
And
lucky, I guess.
the other interesting thing is how my blood test, my cholesterol is lower than it's ever been. My triglycerides are so low also, which could be good news, but I said 123 cholesterol. It's never been that low. And he didn't understand it. He said, "Hey, that's good." I said, "I'm not sure it's so good, but I guess I thought about testosterone, how it could, low testosterone, no testosterone can make your lipids drop drastically, because since high testosterone does just the opposite, causes your lipids to elevate to the point where you're predisposed to having a heart attack when your testosterone gets too high. And so it's a bit of information that's kind of new to me because I'm watching it. My triglycerides are very low. My blood fats in general. So what I decided to do with the creatinine is to start eating a lot of meat. And for the past week, I've been enjoying steaks and lamb chops and all the other things. I know it's, you know, sort of relatively contraindicated with prostate cancer. It's supposedly devoid of antibiotics and hormones, but then again, who knows? But it certainly feels good, and I'm going to repeat the creatinine and see whether or not it elevates it. Or what I put on about 3 or 4 pounds, and I'm hoping some of it is muscle, and the protein. My protein has been low too, so.
Jack, do you
Um,
take rosuvastatin?
I take Lipitor.
Lipitor, okay.
Yeah, 10 milligrams of Lipitor, and
Because this is not just for you, anybody who's taking rosuvastatin, you should be aware that darolutamide will raise the level of rosuvastatin 5-fold in your plasma. So just be aware
but
of that.
not with
Okay.
Avorstatin, not with Lipitor, huh?
Lipitor is like a class, what they call like a level 1 drug interaction warning. But Nubeca darolutamide is like the highest level 3 warning.
Yeah.
So
With Lipitor?
no, Lipitor is a level 1.
Okay, in terms of
Well, I
mixture?
don't know what this level 1, level 2, level 3 interaction is, but darolutamide is the highest interaction level. Lipitor is much minor. I switched.
Yeah.
I also added niacin every day and something else I'm doing too. But I went down to 10 milligrams of rosuvastatin and
Yeah.
added niacin
Right.
and
Well,
find some combination, but don't stay on 40 milligrams or 20 milligrams.
I'm not. I'm only on 10 milligrams of Lipitor.
10 milligrams. Yeah, you can get a little reaction, but it's
Well,
nothing life-threatening at that level.
no.
So I want to just jump in with a couple of things and then go to the questions, Len. I truly believe that the best doctors, and I'm not just saying that because we have 2 of you in here, but the best doctors in terms of drug interactions and are the psychiatrists, because I think it's very much part of your training because people present to you with mental health issues that are layered over the top of everything else that they do. So you guys know to look at drug interactions. But unfortunately, I don't think that that is the way that most doctors think. I don't think that it is stressed in the training. This is just my own personal theory. I don't think it's stressed in the training to the extent that it it's stressed in the training, in the psychiatric training. And that's why, I mean, I know Dr. John, you mentioned a drug, he's already looking at the cross indications and this and that, because that's how you guys are trained. But I don't think we can expect that from all the other doctors. So it doesn't surprise me that you're having to educate your other doctors about the other drugs they're on. They don't even bother to check a lot of times. Now, I'm going to go to Dr. Jeff first because he's I'm not sure. I think you're an internist. I think you're not just an internist, you're an internist, and you can comment on this. But we just don't see it that often. Dr. Jeff, go ahead.
Yeah, Jack, I have a question. I mean, you have sarcopenia because of the anti-androgen treatments. Why is your doctor worried about a low creatinine?
He's
I
not worried.
mean,
He just doesn't understand it. I was the one that was worried. I was concerned because I had never seen it before. He said, I have no idea why. And that's what he said to me. And then I said to him, well, it's probably the sarcopenia. I was wondering if it was sarcopenia in the striatal muscle or was sarcopenia in the cardiac muscle. Because I also have a low voltage EKG that's happened since I've been on this medication. So I've had a consistently low voltage. I started worrying about a myopathy of some kind. And so I'm getting a, what do you call it, an echo this Thursday to look into that. And, it could be either a muscle band or a cardiac band. I don't know which is causing the creatine phosphokinase was also low. So the CPK and the creatinine were both low.
yeah, because your muscles are atrophying.
Right, but I was worried about the cardiac muscle atrophying because I've got such a low voltage on my EKG consistently, and I get one every 2 months.
I mean, you're not in heart failure, right?
I hope not. Not that I'm asymptomatic, but who knows what the ejection fraction will show now that I'm getting, an echo this Thursday. No, I'm not in great shape. I used to be able to run a lot and do a lot. I get out of breath more easily. I have much more fatigue. My hemoglobin's down, everything's down, so I can't tell what's going on to make me feeling the fatigue and slight shortness of breath and all the other things that could be possibly, something with the cardiac muscles. Or it could be just the hemoglobin, or it could be, who knows. But this medication is so tricky. Most physicians, I don't think it's just psychiatrists. I think most physicians, either they're overworked, preoccupied, disinterested, or just ignorant and unwilling to stay up to the minute when it comes to this particular medication. And you talk about cardio-oncologists. What about rheumatologists? What about electrophysiologists and so many other doctors out there that have no idea about these new drugs? They're so new. Very few know about darolutamide or apalutamide or.
That's why we say here, Jack, as you know, you have to be your own best advocate.
We have to be, and you guys are the guys who educate me and keep me up to the minute. And my medical oncologist, who's very good, and he knows about this stuff, as does my radiation oncologist. But they do it every day. These other guys.
Yeah. All right.
Steve
Rue, go ahead.
I just wanted to comment on the whole trigger finger thing, and when I was on aleuprolide, I was having some bone pain and hip pain, and I was getting finger pains, and I got the trigger finger pretty bad in one hand. But now that I've been prescribed the Orgovix with the prednisone, and my guess is it's got something to do with the prednisone or maybe the Aleve I've been taking, but trigger finger's gone, and the hip pain, which my PC said bursitis. It wasn't, I don't think it, but that's all cleared up with the. And I'm guessing it was because of the prednisone. I just wanted to say that. Thanks.
No doubt about
it. Steve, why were you taking prednisone with Orgovix?
Well, Dr. Heath recommended that. She said that it would help some of the other side effects of the Orgovix. mainly the fatigue that was really my major first worst side effect problems I was having with the Leuprolide. So she thought, well, we'll do the Orgovix and we'll hit you with some prednisone and see what happens.
What was
And
the
it's
dose?
oh geez, don't get me lying. It's a really small pill. That's all I know.
They're all small.
That's a
Okay.
new
But
strategy
it's
on
really
me.
helped with the fatigue and the trigger finger, I guess.
Mhm.
I take
John,
prednisone.
were you talking?
I'm
No,
sorry for if I interrupt. I was just going to say that's a new strategy on me. I always say
Yeah.
that prednisone makes everything feel better. I guess this proves it.
no.
I took
Yeah.
Guys,
prednisone for
Works.
you're
20
losing a piece of information here that Steve didn't mention. He's also an abiraterone, as I understand
Oh, oh,
it.
Uh-huh.
so,
Yeah, I
so
forgot that. Sorry.
you
thank you.
forgot that part. So let us just add that
Those are big pills.
yes, but the reason you're getting the reason you're getting the prednisone is because you're taking the abiraterone. Dr. Heath
Correct.
didn't prescribe the prednisone to help you with the side effects of everything else. She gave it because you need it when you're taking either 10 milligram, 5 milligrams, or 10 milligrams, depends on the doctor's choice, and either once or twice daily. But I don't want people starting to think that, if you've got all these side effects from Orgovix, you can get you can get prednisone. No, that is not the case, and not what Dr. Heath did. Jeff Marchi.
Yeah, just I've got trigger finger and three fingers of one hand while I was on prednisone and Zytiga and had to have it treated. And I got it on another finger on the same hand a couple of months ago, but cortisone fixed that one. On darolutamide for a year now, my creatinine has stayed at 1.0 for the whole time, and I then my cholesterol. I can't take a statin. They just screw me up. But my cholesterol is 139, and
That's good.
I eat almost no meat. I ate chicken and turkey, but with a lot of fish, but almost no red meat at all. So my creatinine stayed good without having to eat red meat, I guess. 1.0 is supposed to be less than 1.34, I think it says. Less than 1.34, yeah, that's the normal value.
Well,
Have they really
I'm
figured
kind
out
of
your number is that it's a problem that it's low?
no, it's a problem in my head.
Oh, okay.
Okay, because it just seemed very atypical, and
Yeah, it does. It did
Oh,
sound a little
okay,
low.
John. Dr.
I
John, go
just,
ahead.
I, I'm just hoping that after you do your experiment and figure out the effect on your muscle mass and your creatinine, that you're able to go back to your old diet. Because I'd hate to see you having steaks going forward from now on.
I had my last steak tonight. I'll have my
Oh,
indigestion with it. But it feels awfully good though for a while. It's been away from it
Look,
for so long. I mean, God, it felt good. Such a
what
manly
I
thing to
say
do.
to all you guys, and I stick with this, is have a steak. If you love red meat, have a steak once a month. It's not going to kill you, man. Have once a month. Just don't eat it every night. Have a lamb chop once a month. That's okay. But you've got to predominantly make your diet a certain way, and the stress from not eating any of this stuff can be worse. So
I
if you say Dr. Rick said that, okay?
Okay,
I think Dr. Rick is right about that. It's the overall pattern that makes the difference.
agreed.
Eat
Uh,
a corned beef sandwich, Jack.
Talking of heartburn. Okay.
Jeff, what do you think of that observation of mine about a lot of docs just not looking at the cross interactions, and what do you think we should be doing as patients? Do we have an obligation to ask our docs to be looking at the indications, the cross indications?
So it's the easiest thing in the world for a provider. My doctor does it. What medicines do you take? You put it in a computer, you just type in the names of your medicines, and it tells you clearly what interacts with what. So if they're not doing it, they're either being lazy or they're overworked.
Overwork.
But I would definitely recommend, since it's so simple to do, everybody should do it. Just there's like multiple websites where you can go do drug interactions. And if you see that you're taking drugs that are not compatible with each other, you got to tell your doctor. I mean, if you know it and they don't, shame on them.
Steve Rue just put something in the chat, drugs.com.
That's what I use.
They have a great interactions guide. You just plug in the drugs you're taking. You can put in 1, 2, 3, 4, as many drugs, and it'll tell you what the interactions are. Adam, go ahead.
No.
Oh, no, I'm sorry, Julian.
Yeah, one thing I do is I talk to my pharmacist, and he gives me a lot of good feedback on how these drugs interact and what to do and not do. It. Even ask my doctor, did you think about this or not?
Yep. Always good to ask the pharmacist. All right. Why are you laughing?
Well, I'm laughing because of the source of the comment.
Oh.
I'm laughing because of the source of the comment. What's that source going to say? Don't ask the pharmacist.
Right, yeah.
Well, I'm
right.
laughing too because pharmacists have saved my ass many times.
There you
There
go.
you go.
Put
Right.
a halo
All right.
over Len's head.
Took.
But Len's a pharmacologist, right? Not a
Yeah,
pharmacist.
I'm not a pharmacist in the sense that I've ever dispensed drugs. That's a whole different profession. Let's go to Took.
Well, so thanks, Len. I mean, I just started my MRT session today, and I thought I'd have a consultation with my radiation oncologist, but all I did was just go into the treatment center and then have my get zapped. So should I be concerned that all I talked to was the radiation therapist instead of the actual radiation oncologist, or
In my
just
particular case, too, um, I I saw the techs every day, of course, and I saw either the nurse or the radiation oncologist maybe once a week or once every 2 weeks or something. So I think that's probably standard practice. Did you get the brachytherapy seeds?
uh, no, not yet. I was going to have a consultation with a different radiation
Okay.
oncologist that specializes in that. In
Oh, good. Okay.
brachytherapy. So yeah, right now I'm just starting on IMRT,
Did
but
you
it
get?
seems like nobody's really informed me of what to expect. Like they didn't really go over any like margins of what they're going to treat or like any plan. Um, the tech
Well,
told
we
me
can
I
do
probably
that.
could. Oh,
We can
okay.
tell you what it's like to be on IMRT. But as far as the diagram that shows the margins and how they're aiming it and everything, you have to sit down with the RT at your appointment, radiation therapist, and they'll show you the pictures,
Oh, okay. I mean,
hopefully.
is it normally 70 gray for the over the course of 28 treatments, or could it
Yeah,
be? Depends on each RO.
It depends on your
So,
RO. My prescribed dose, I think, was 74 or something like that. We're all a little different.
I see.
no, I mean, the answer is no, it shouldn't be as high as 70 if you're going to get a boost. So
Oh, yeah, yeah.
this is not salvage. This is your initial treatment. So if you're going to get a
Oh,
boost, which would be to the prostate gland from brachytherapy, then you should not be getting 70 grays. Now,
oh,
if you're concerned about that and you're in the Kaiser system, you just need to put something in your portal right away saying, when am I going to be meeting with when I'm going to be meeting with you, doc? Am I getting a boost or am I not getting a boost? And if I am
oh,
getting a boost, how much am I getting initially? But it's not unusual not to see it. I mean, I would not expect to see the RO on the first session. I'd expect to see him. Usually they meet once a week. So after you've had 4 or 5 sessions, you would be seeing them. But you do need to clarify whether you're getting that boost or not, because that could affect what you get each day.
okay. So 70 gray plus the brachy boost would be just way too much radiation for the
It would be
for the
too
prostate.
high. I don't want to say way too much, but it would be too high. If you
Oh,
were getting, I think I got about 50. The problem is, and I've never understood this, but tall Alan Edel explained it to me one time. But the radiation, you can't just add the radiation from brachy to the radiation from IMRT, and I'm not exactly sure why. But
Oh,
in my case, I got about 45 grays from IMRT, and I got about 52 from the seeds.
oh, okay. So if that's the case, maybe my treatment won't be 28 sessions after all, right? If they're gonna, or
Well, if you're getting 20, my guess is you should be getting between 20 to 25 if you're getting a boost.
okay. Yeah,
But
I'll
that's
have to
what,
check with my
but,
doctor.
but you've got to go back to the doctor, write something in there tonight and say, I have my first session today, doc. Please, can you explain to me how much I'm getting in IMRT and how much is going to be in the boost to the prostate gland? And if he comes back and he says, well, you're not getting a boost, you'll know that you and he are not on the same page where it comes to the brachytherapy.
Okay.
Because
I mean,
what you should be getting, and we've talked about this before, we can't go over it again now, is you should be getting either brachytherapy, either high dose or low dose, or SBRT to the gland plus IMRT to the pelvic girdle, across the pelvis,
but
to the pelvic lymph nodes.
even though there was no lymph node invasion on my PET scan, I mean,
Correct.
oh,
That is the standard of treatment. We've talked about this a couple of times now, Took. I know I with you and in the group, but the standard of care for T3B, the gold standard of care for T3B is radiation across your pelvis to knock out anything that might be there, which is what I got because there was nothing that they saw that was there. And then treatment to the gland, either seeds, high dose brachytherapy, or SBRT.
well, thanks for clarifying this, Rick. I have to talk with my doctor again about that, about radiation to the pelvic area.
Well,
Speaking of
All right,
which,
we've got Dr. John and then Dr. Jeff. Questions, go ahead, or
I
comments.
wanted to ask Took if his promise results have come in yet.
yes, my promise study results did come in, and the germline test came back negative. So,
Okay, good.
does that
Thank
mean
you.
I should get another germline test? or just
No,
just
you
to
don't have to get another germline test. That's not going to change. Maybe,
okay? Is there
maybe in the future, maybe in the
do you think there's
future.
a difference between a saliva swab versus a blood sample, or they're both
No,
considered
both the same, I
accurate?
would say.
Okay, thank you.
Dr. Jeff.
Yeah, so you started your radiation therapy without having a consultation with the radiation doctor?
I mean, yeah, I've had some video calls with him, but that was only the initial stage of deciding which treatment plan I was going to go with. I originally decided on SBRT, but then changed my mind to IMRT. And then later on, I wanted to, from this group suggestion, I wanted to ask him for additional brachy boost after my IMRT session. So I got an appointment with a doctor for brachy that specializes in brachy therapy, but that's like maybe next week or within two weeks. So
But
that's
you
why.
had video, you spoke to the doctor though, even on the internet, you had a conference.
Yes, yeah.
Okay. Because personally, I think everybody who's going to get radiation should see the radiation oncologist before the treatment starts.
Okay. Okay. Yeah, I did see him, but yeah, he didn't really outline what actual plan was. So that's why I was kind of concerned because it seems like I'm in the dark right now. I'm always have to initiate the conversation rather than him, offering it up to to me.
No, you need, and you should tell him um, in your email today that you want a complete treatment plan from him. Now he may come back to you and say, "Oh, well, you haven't told us whether you want to do the brachy or what you want to do." You could expect that if you haven't seen him, but the question is, what is he treating you for right now? And you need a complete treatment plan. I mean, I would not start radiation without knowing how much they're going to put across my pelvis, and how much they're going to put in the gland, and when they're going to put it in the gland. Because if
Right. Yeah.
he's radiating your prostate gland right now, you're going to go to the brachytherapy, and he's going to say, "Oh, I can't give you brachytherapy. You already had radiation to your prostate gland." You say, "What?" So
Okay.
you got to get this. It's up to you to get it. This is Kaiser, so it's up to you to be your advocate. Unless you've got
Right.
a good doc there that you're working with, a lot of times stuff just gets done.
Yeah, they're probably overwhelmed with their workload
No,
treating stuff.
forget the overwhelm. That's not an excuse for me. Each patient is a
Okay.
patient, and each patient's entitled to know what treatment they're getting. Overwhelmed is bullshit.
Yeah. Yeah. No, I appreciate the feedback from this group. Without this group, I'd probably be, lost in the woods.
Okay, I think we should
So
move
thank you
on
very
then.
much.
Yeah. All right, too. Thank you. And we'll go to Peter Monaco. Go ahead, Peter.
Hi. Yeah, I just wanted to give an update on my situation. Just to refresh, after 3 years on Zytiga and hormone therapy, ADT, I had a PSMA PET scan, which showed that the bone mets, I had about 4 or 5 bone mets in my spine, had diminished to a point where they were no longer detectable, but that there was one lymph node on the paratrachea that remained, that was there at the beginning of my, my round of with Zytiga. So my oncologist, Dr. Patel, recommended that I go for spot radiation, SBRT, and I'm happy to say I finally completed that. It was 5 rounds. After much delay, scheduling, insurance, I had to do my simulation twice because it was pretty dicey where the paratracheal is, shooting the radiation in and not, hitting the lung. That was a big concern. But I met several times with my radiation oncologist before and after and during, actually. He's a pretty good guy. And so that's it. I'm on monotherapy now of Nubeqa. My PSA has been good, 0.009 last week. I don't think I'm going to get another PET scan, though, for about 3 months. In my discussions with Dr. Stewart, the radiation oncologist, he said to come back and see him in 3 months, and I've got appointments set up with him, and they would discuss doing scans at that time. My medical oncologist, Dr. Patel, seems to agree with that. So right now, I'm hoping that the radiation hit the spot, so to speak, and maybe at least decrease the size of that lymph node on my paratracheal. So that's basically it. I just wanted to give that update.
Sounds like you're ready for a nice drug holiday, Peter. Did they talk about that?
In fact, yes, Len. In fact, I did discuss that with Dr. Patel, and I was talking about you, and he knows you. He saw you speak somewhere.
Yeah, he did.
Yeah, and he said, I told him that you had some luck with going to a half dose of Nubeqa, and he said we could definitely consider that. We'll wait for another couple of PSA tests. I'm getting tested every 2 months right now. But that we can definitely consider doing that as a next step, and then possibly take a break altogether if it continues to go well. So,
I've been going to Mount Sinai. They don't do ultra sensitive PSAs as far as I know. They've never gone beyond the 100th decimal point, but
yes.
0.009. That was from Sinai?
Well, that was from LabCorp. My lab order from Dr. Patel says specifically ultra sensitive. So, my first PSA test with them, LabCorp, was 4 months ago, and it was 0.008. It did increase to 0.009 with this one. I don't know if that makes a big difference, but
you're talking about 1,000th of a nanogram.
Yeah. If I was doing it at Mount Sinai, I would still get the 0.02. So, I wouldn't know the difference and still be happy thinking that I'm undetectable. But yeah, the LabCorp could take it out to 3 decimals.
All right.
So that's my update, and I'm
right.
pretty pleased with the way it went.
And my feeling on that is you guys should stick with the test that Len gets, because we get too many guys that get neurotic about it going from 0.008 to 0.009, and you don't need it. It doesn't matter. So don't ask for an ultra. Don't ask for an. I guess what he asked for was an ultra sensitive, which is what Len gets, but not. And what LabCorp gave you is an ultra sensitive. So next time you go to LabCorp, tell them you only want the ultra sensitive.
I guess. I mean, I thought LabCorp would only give you as low as 0.1 on their regular test. I'm not sure, but thank you for telling me, suggesting that I should not drive myself crazy from going from 0.008 to 0.009. It's not significant. And
no, look at Frank Chambro rubbing his head there. I can say I'm watching him, and he's thinking, "You guys are nuts. You're worried about 0.008 to 0.009." I can hear him. I can hear that New York accent telling us we're all a bunch of lunatics. Go on, Dr. John. What's on your mind?
I was just going to add along those lines that Yale has changed its PSA assay. It formerly detected down to 0.008, and now it only detects down to 0.015. So apparently they've decided it just caused more trouble than it's worth to get those tiny numbers.
Yeah, that's great. That's good to know. So,
You know,
I would just like to make a shout out to I don't know what's going on with the broadcast right now, but
Yeah, mine too.
yeah,
Mine
it's
has
like
crashed
absurd.
4 times. Yeah.
Yeah, it keeps changing. But
Oh,
I was
nuts.
listening to some of the gentlemen who um, had spoken before me, specifically Frank Cumbra. Um, you know, about 3 years ago, I was in a place that I thought was pretty low. I had gotten a PSMA test, thinking I was doing well, and but my PSA started rising, and they found several Mets on my spine and the one on my paratracheal. And after 3 years on Zytiga and hormone therapy, again the PSMA scan I got about maybe 2-3 months ago showed that the bone mets had gone away and the one lymph node remained on the paratracheal, and I felt kind of hopeless. And before going through this 3 years of Zytiga, so and it seems that right now I've got my disease a little bit more under control than I felt I did. And just don't give up hope. Don't be like me, because I had myself 6 feet under, I could tell you, 3 years ago. And if it wasn't for guys like Len and Rick calling me up and give me encouragement to, don't feel that way, just keep fighting. So that's the message I'd like to relay to Frank and the others who spoke, who are dealing with some difficult disease right now. You never know; it could turn. Hopefully, God willing. That's all I had to say.
thank you for saying that, Mr. Monaco. And I think it's really it's great encouragement, and yes, we appreciate. We did have to pull you off the ledge a couple of times,
Yes,
right,
you
Frank?
did. You
Right,
did.
Len? We had to pull you off Peter off the ledge a couple of times, but
Yeah.
just I always like to say to people, David Muslin isn't on here today, but Dr. John is. I always like to say to people, stay in the moment as best as you can. It's hard. It's really, really hard. It's real hard to clamp down on that monkey mind. But if you've got techniques to help you do it, then use them. And if you don't have techniques, talk to us and we can point you to places where you can develop those techniques, or come to Men Speaking Freely and we'll help you develop those techniques. But if I asked Peter Monaco how much energy he used up making himself nuts, I don't think he could. I don't think there's a number big enough.
No, no. I always wondered. It was a little over 3 years ago, again, that I gave a very difficult update after having gotten an asthma scan. And you remember that discussion we had about my former oncologist who didn't think that scan was necessary, leading to my changing to Dr. Patel. And, I was in a very bad place after giving that update, getting a lot of feedback from you guys. And you, Rick, and Len, and Jake, God rest his soul, each of you called me individually, within a couple of hours or maybe the next day after that meeting, all with the same message, don't give up. And it meant so much to me. And, you know, it was very helpful to, hear words like that and think that it wasn't over and I still had a chance. And, then I made maneuvers, changes based on the feedback I was getting from you guys about, you need a new oncologist. That was something that came out in the wash, and I did. And now I'm with an oncologist who I have a lot of faith in, Dr. Patel. I think he's very good. So
Yeah,
thank you. Thank you.
I like him too. He's very good.
Yeah, yeah.
All right, let us go now to Richard Fisk.
Okay, just a quick update. Diagnosed with Gleason 4+5, middle of 2022. Had external beam and high dose brachytherapy. Been on 24 months of ADT with Lupron and abiraterone, and 24 months is up next Sunday with undetectable PSA and undetectable testosterone for the last year or so. I have an appointment at Rick's suggestion with Dr. Peller at Sibley in January, and I'm just wanted to report that. And other than other than the standard and diet and exercise exhortations, what should I be doing or looking for?
You mean when you go on drug holiday?
Yes.
You should be looking to enjoy your life a lot more.
What I'm concerned about, obviously, is dormancy and how to either keep the cancer, any existing cancer, dormant, or to kill what's there, or like I say, prevent it from manifesting again.
I think if anyone knew that, Richard, we'd have so many cures in prostate cancer.
Well, that's why I'm asking you guys, because you're the brains.
Well, we know a little bit, Len. We don't know. We don't know what Len, as far as what Len's talking about. We don't know a pill to take or a thing to do to prevent, but we do know that your chances of recurrence may be able to be delayed if you eat well and exercise well.
Mm-hmm.
Yeah.
Yeah, I understand that, and need to trade some fat for muscle and get some muscle mass back.
Richard, I have a question for you because I'm just looking at my notes here. Your original treatment before you started on the Lupron, or maybe not before you started on the Lupron, before you started on the Abbey, was, am I correct, HDR and IMRT? Is that right?
Yes.
Okay.
Well, no, I started the ADT before that.
Right. Okay.
I started about 2 months before that, and in fact, both the prostate and the tumor shrunk by the time I actually began radiation.
So, you know, your situation is sort of a little bit unusual in the sense that when you were diagnosed, you were suspected to have de novo metastasis, but it wasn't exactly clear. And then you got treated with what we would treat somebody who was very high risk. And so, in a sense, it's not really a drug holiday you're on right now. It's basically a completion of treatment.
That's what I was told.
Right.
The issue with possible metastasis was that there was a projection of the tumor that was leaning against the rectum, and I had a flex sig with ultrasound that determined that all 5 layers of the rectum were intact. So the assumption was that there was no invasion.
Well, I'm not looking at that. I'm looking at the fact that there was something suspicious on your floating rib. That's what I'm not talking about, the local.
Okay.
But we don't need to get into that. The point is that your treatment has been basically an initial treatment, and we hope you're done. Done. Now, the reason you're seeing Dr. Palla is because you need an ongoing doctor to monitor you outside of the VA system. And that's why we suggested you go see Dr. Palla. So when you meet with Dr. Palla in January, I think what you should be telling her is, look, I've selected you because I don't want to continue my monitoring in the VA system because they don't really have doctors for me if the disease comes back. And so how would you treat me? I hope I never have to see you. You're a very nice lady and you're very, very smart and you come very well recommended. But I don't really need to see you, but I need somebody in my camp in case it comes back. How do you recommend we monitor this disease? That would be my pitch to Dr. Pala.
Okay. Let me scroll this down. And that was what I was told by my hematology oncologist when he said that I would be finishing up on the 27th, that I would be handed over to the urologist at Fort Belvoir, and then it evolves that at Fort Belvoir, I wouldn't go back to the radiologist, I wouldn't go back to the urologist, I would be monitored by the radiation oncologist, which seemed a little far. It seemed to endorse the idea of moving to Dr. Paller, who would be front loaded if anything untoward came up. She would be ready to deal with it. So that's
We have hands up. Dr. Jeff.
Yeah, so Richard, you're going to come off prednisone on the 27th also, and you need to make sure they give you a tapering schedule. You just can't stop the abiraterone and the prednisone simultaneously. So make sure they give you tapering, week by week, what your dose going to be.
I have an
So
18-day taper.
that's pretty fast. How much are you taking? 5?
7.5.
Well, 18 days is pretty quick. I wouldn't accept it.
No.
I wouldn't accept it. I would tell them, hey, I want to talk to someone else. 18 days, you've been on it for 2 years, the prednisone?
Mm-hmm.
18 days is way too fast.
Yeah.
Okay, basically it was drop 1 milligram every 3 days, and then at the end 1 every other day for 3 days.
It's too fast,
Wait,
Richard.
too fast.
Dr. Jeff is telling you that. Jim Marshall
Well,
shaking his head. I'm telling you that. Don't ask
Well,
us.
Way too fast.
It's way too fast. Don't ask us. But you've got to go back and say this is way too quick from what I understand. And we've seen guys who come off too quickly, and then they have all kinds of different side effects that you couldn't even imagine right now.
what
Wonder if there's anything in NCCN guidelines on prednisone withdrawal or weaning. Does anybody know? I've never seen it.
I don't know.
what have people seen? I'm not asking for a recommendation. I'm simply asking what people have used or seen.
Yeah, so people
Anybody
become
would
Addisonian. You don't want to go into Addisonian crisis because you don't have enough steroid in your body. You got to give
Well, that
your adrenals time to recharge so that as you're getting rid of the prednisone, your own adrenal production goes up. And 18 days to expect that is, if someone told me when I come off my prednisone that I'm giving you an 18-day wean, I would go find someone else.
Jeff, what are you hoping to see? What type of schedule are you hoping for?
I would say between minimum 6 to 8 weeks of cutting.
Right.
and a linear cut.
Yeah, yeah. Maybe, you started at 10, bring you down to 9, 8, 7.5, 7. I mean, there's no rush to get off it.
Hmm. Okay, and I'm just getting a refill of 120 5 milligram pills.
Good.
Jim
So
Marshall, you've been through this. How long you were on for 4 or 5 years? How long did you take to get off of it?
Okay, I was on for 5, so I did 2.5 for, let me think here, 2 weeks. I went 2.5 essentially every other day for 2 weeks, and then I went 2.5, okay, every third day for the 2 weeks and stopped it,
so
if I
6 weeks.
remember correctly.
it's essentially linear with a slower taper at the end.
Yeah, that's the thing I did, but
But Jim, you didn't start with 2.5. How much were you taking when you at
oh,
the?
I started with the 5, okay, and I dropped it to 2.5 for 2 weeks, and then it was a 2.5 every other day for
Right.
2 weeks, and
Right.
then 2.5
Who
every third day for
right.
two
Who
weeks.
else anyone else uh tapered off of abiraterone on this call right now? Jeff Marchi, you must have done. You were on Abby for a while. What was your taper?
Yeah, I went to a half for about a week and a half, and then that about a quarter for a short amount of time. And I didn't taper long enough because I had some major fatigue problems when the first few weeks after I came off it, and I needed to take a nap every afternoon. It just I didn't taper enough.
Okay,
You
Uh,
really
but
get
uh,
you get a lot of
Greenfield.
fatigue.
Dr. Jeff, you're you are saying that 6 to 8 weeks of a linear taper would
Yeah,
not be unreasonable.
I would go to an endocrinologist and work with an endocrinologist on your tapering. And as you cut your prednisone and you go lower and lower and lower, and you get a cortisol level and see what your own body is, ACTH and a cortisol. See what your body's doing.
Okay.
Great idea. Jimmy, you had a comment or question?
Oh, I did. So this present prednisone talk is interesting. I'll only say that I tapered off it pretty quickly, but it was after 4 months, 5 months of it, and I tapered pretty quick. But I was on Lupron for quite a while after that. So any fatigue symptoms or anything else, I probably would not. I'll never know. It was a quick taper, but that's not what I wanted to say. What I wanted to say is, of course, Richard, you know, I always say this, and I didn't make this up. If exercise was a drug, it would be the first thing prescribed for what you're trying to do. You want to sail on. You don't want to recur. You want to do the best you can for yourself. And I heard you say that you want to switch out some of your fat for muscle. Did you say that?
Yes.
Okay. So I don't mean to be too direct, but have you been doing that, or is this a plan you have?
No, I have been exercising. I've been about 20 minutes on the elliptical, 5 or so days a week, and then some upper body weights 3 to 4 times a week.
Great. Whatever you're doing, I always say that if you can safely do more or more intensely or get a trainer and up it, the more you do safely, the better you will feel and the better your odds will be at having a healthy life in every respect. And that's so obvious to say, and I'm always the one to say it. But I'm such a believer that there is data for this. What you're doing, your cardiovascular exercise is keeping the mitochondria flowing, and keeping the mitochondria flowing when we get older, when we're not making it anymore as much, is really, really important. And so it's all matters, but someday they'll finish all these studies and there will be lots of hard data, but we don't need the hard data. You can see for yourself. people that stay strong and fit fare better into old age, regardless of whether they have heart disease or not. And you sure do want to continue on and not have to be back on the drugs again. And that should be motivation enough. But for anybody who is, I always say train when you're on ADT. Don't wait until you get off it and your testosterone comes back and you feel like you'll be up to it then. This is a real mistake. The time to do it is now, no matter what state you're in. And it's hard. It's real hard, but it gives us a better life every single time.
I appreciate that, Jimmy.
Yeah.
I was a diver in the Navy, so I have kind of a lifetime habit of
Say no more.
kicking my ass down the road.
There you go. You're used to it. Good mode.
Very good advice, guys. Very good.
Yeah, thank you for the
Jim,
information
we're-
on
Marshall,
the
we're-
taper. I had no idea about that.
We're back to you, Jim.
Yes,
Jim Marshall.
Captain Fish, actually, it's a nice thing to see that you shaved and a haircut. You look much better.
Well, thank you.
You said that your treatment ends in a few months.
Few weeks.
I don't agree with that because what I believe you will be going through is, I believe, a PSA test every 3 months for a year. Is that in the cards?
I assume so. I've got one before.
Because a sidebar issue for the VA point of view, you would still be under treatment collecting 100% if you assert that. So I
Okay.
wrote a paper on it and I will ship it to you tomorrow.
All right.
Okay,
Yeah,
how that works.
I'd also like to say from one captain to another captain, you might want to attend the vets meeting tomorrow night, Captain Richard, because a couple of things occur to me. One is, and I don't know, it may well be that Pala is covered through your TRICARE. But if not, you can probably get it covered through your VA. But definitely as a community oncologist, because there's no GU expertise at Fort Belvoir. So I know that Captain Jim will sort you out properly on that. The other thing is, since you got a haircut and you got a shave, we have to ask you, how did the performances go?
The performances went well. It was a tremendous group of actors. We had fun every night, and had people say that their sides hurt by the end of the show.
Fantastic.
That's all we can hope for.
Fantastic. That's the report we were really looking for. You know that.
Yeah, and I can't make the meeting tomorrow night because I'm rehearsing for a show called Voices from Vietnam. That's a series of monologues about people's experiences in Vietnam.
Well,
no problem at all. No problem at all. I will ship you the paper I wrote. I just finished it today.
Thank you very much. I appreciate that, Jim.
Thank you, Richard. Well, I don't have anyone left on my list. Was there anyone who came late that has like time to speak?
It's John. I can make a comment while people are thinking about that. I've been reading through the NCCN guidelines on ADT, and I'm scanning, of course, because it's so big, but I don't see anything on suggestions on how to taper the steroid.
Okay. That's an omission that needs to be corrected, I would say.
Yeah, and we're still making comments, and that's down to me, and I just haven't had time to finish, but we're still commenting on the patient guideline, and I will be sure to include that because I'm working now on the part for the metastatic part, and I'll try and get a comment in there that there needs to be some consideration in the guidelines. What was the other thing I saw today? Oh, that with that with the use of Akiga, which is the PARP inhibitor and the abiraterone together, the guidelines don't talk much about who qualifies. All they say is you shouldn't have been on more than 4 months abiraterone. And I think the trial, which was the magnitude trial, I only know that because I happened to read it today, didn't allow anybody who had more than 4 months or had been on a prior ARSI, but that's not even addressed in the NCCN guidelines. So there's a couple of things that have to go into those guidelines, and I will remember. And I think Jeremy has his hand up.
Just real
Yep.
quick, on my second week of radiation and Orgovix, does anyone have any experience with vibration plates?
Vibration plate. Oh,
Yeah.
Larry, I don't even know what it is, but Larry does. Go ahead, Larry.
Well, I have this thing. It's the name of it is like a Roblox, but it's not the game Roblox.
Yeah.
It's a thing you stand on that vibrates up and down, back and forth, left and right.
Yeah.
And you can do intensity and time. It's very good I found it good for balance and neuropathy. Is that what
Right.
you're talking about?
Yeah, for bone density too is what they say as well.
Yeah, I
Yeah.
mean, you don't need bone density you can get by walking, running,
Sure.
exercise, weights. But I liked it for stability, balance. I
And I
bought one. It was like $200-300
I just want to say I've
for
got
good, for a really good
my
one.
Embr on.
Oh, he's got his Embr.
Yeah.
He's got his
You know,
Embr.
I don't.
Rick, I wanted to say one thing about prednisone. If you can get it as pills, you can self taper. They're giving you more dose, larger doses. You can take half of that, double the time, or whatever level you want. If they're like you're feeling like it's too fast, of course I would not recommend people to take medicine without the advice of their doctors, but I would recommend thinking about that.
Okay.
It's what I did after chemo and slowly tapered off the meth.
Let's just come back to Jeremy.
Yeah, sorry.
How are you doing on your with your any have you noticed anything yet?
Well, can you hear me?
Yes.
Yep.
Oh, on the organ, I'm getting the occasional hot flashes. A little, the dietary change because you got to have empty bowels in the morning. Wasn't too difficult because I was doing intermittent fasting anyway, so I wasn't really eating in the morning.
All right.
And that was mainly to control diabetes, not weight loss. But I have lost about 4 pounds, and so the doctors are watching because you're typically, I guess, on Orgovix you gain weight. But I work out a lot. I do the cycling twice a week, and I do a pretty rigorous Orange Theory workout 2 to 3 times a week, and then yoga 2 to 3 times a week. So I'm pretty busy, so I don't think I have a problem.
Okay. Well, keep us posted. And Dr. Alfredo, it's nice to see you. We haven't seen you for a long time. What's going on in your world? Have you found yourself a good GU medical oncologist? Are you seeing Dr. E or anybody else?
Well, I will see Dr. E eventually. I've been away because, there are other aspects of life that get in the way, and I don't really have much to report. I'm 11 weeks into my Lupron therapy. I had my blood drawn just a few days ago. My PSA is finally, my testosterone is still undetectable, which it was 4 weeks ago. My PSA is now exactly 0.4. And Dr. Choi, the radiation oncologist at MD Anderson, said in our last call that he wanted to wait until we got to 0.4 before we schedule the IMRT. So next week I'll have more to report, but this week I don't have much.
And how are you managing on the Lupron?
Pretty well, actually. Mostly fatigue, more hot flashes now than before. You know, three to five, 6 a day, hot flashes, but they're tolerable. So I think I cannot complain. You know, under the circumstances. So next week I'll know more. And in the meantime, as we all know, other people have much worse medical adventures than me, but I've had carpal tunnel surgery on one hand. The other hand is going to be done next Friday. And I did have a trigger finger, but I don't relate it to the Lupron or anything related to the prostate because I had the carpal tunnel symptoms at the beginning of the year. Steroids
Okay.
kept me going for 5 or 6 months. And then when I finally said, okay, now we have to operate, we just fixed the trigger finger at the same time. So
Okay.
So I'm just being a good
Okay.
listener today. I don't have much to teach or report.
Well,
I will say
I
one
just
thing. I won't apologize. I mean, I feel like I should apologize for my many colleagues in internal medicine who don't know anything about drug interactions. I'm sorry. Uh, but that is generally true. And I would say a lot of physicians, they know what they do. They know what they prescribe. And I'll use the prostatic example. If you see a urologist, typically they say, well, I could do a prostatectomy. And that's the end of the paragraph, the end of the page, the end of the chapter. They just stop right there because that's what they do. And they don't say, of course, you could have 12 other options. So unfortunately, a lot of my colleagues know what they do and they don't go further.
So I have a question to follow up on that. I mean, you were the CMO of a very, very large medical system with Sutter.
Yes. Yes.
When you were there, did you address what was expected of the docs in terms of knowing the drug interactions?
Oh yes, but that's a story for many glasses of wine and a
Okay.
very long evening. No, yes, I did. But at that time, I was kind of on the bleeding edge of arguing that the purpose of the system was to deliver quality health care. And while there were many who supported that view, there were many who said, no, no, no. The purpose of the system is to make profits. The purpose of the system is to pay big bonuses to the executives. And certainly, we've never had doctors in leadership, so we really need to focus on what the hospital administrators want to do. And I'm saying that about as politely as I can. So, so what I've learned over the years is good thing. A lot of the teaching that I did 20 years ago has led to the fact that chief medical officer is now a commonplace term, and many CMOs get to work on quality. But when
Yeah.
I started my career in the administrative part of medicine, there were like 11 physicians in America who did anything remotely like that.
Wow.
So,
Wow.
so we've come a long way, and I think we should be proud and pleased. But there's a hell of a long way to go.
Okay. Now, let me just get back to one thing for you, and then I'm going to touch base with Dr. Jeff to see what he thinks of that comment. But
Good.
did you see Jeremy lift up his wrist? Would you lift up your wrist again? Thank you. He's wearing a gizmo called an Embr, EMBR, and it is an FDA approved device which helps not everybody, but helps a lot of guys with hot flashes. Is anyone else got one on? Jeff Marchi usually. Oh, Keith has got one on. Jeff Marchi usually has one on. But what they do is, and again, one of the docs on the call will correct me, but they sense a nerve that's in your wrist,
Yeah.
and they're able to add either cool or heat an instance before your body feels it, and it basically quashes the response.
Great. I'll
So
look into that this week.
EMBR. I'll put it in the
Rick,
chat.
I, ha-
Yes.
I have to call on Keith. I thought he left, but I know he wanted time, right? Did you come back, leave and come back, Keith?
No, I didn't. But I think that Len, my questions got substantially answered in the conversation with Frank.
Oh, okay.
So regarding Pluvicto and so I think I'm good. Thanks.
Oh,
Okay.
are you sure? Sorry, Keith.
Yeah, sorry about that.
No, that's it. That's okay. Um, no, I just, I kind of discussed, and I think Rick, you mentioned that in some cases, there's an increase after first Pluvicto treatment, and just setting my expectations around. I'm feeling great after my first Pluvicto, um, but I was disappointed to find that my PSA is continuing to rise, albeit very slowly. So I'm on kind of a 250-day doubling time from my last test. So I'm I'm in wait and see mode, but that was disappointing when I got my last PSA a week ago.
There were a couple of papers at GU ASCO this year specifically on that. And most people, or a good portion, I can't remember the percentage, did see an increase after their first. And Keith, I think I've got a copy of the paper. I think I took a picture of it. And if I have it, I'll send it to you.
That'd be great, Rick.
I think it was from a guy, it was from a doc in Kansas, at the University of Kansas, an Asian doc at the University of Kansas. I will definitely look for it and send it to you. So yes, hang in there, man.
If you don't have it, Rick, it comes that one of my best friends in high school is a sales rep for Novartis, and set up Pluvicto centers for the past
Okay.
2-3 years. So I can always check with him too.
Hey, he may have it, but
Yep.
don't rely on we've done a lot of work. Don't
Yeah.
rely on Novartis,
Yeah.
but you can try. But I will definitely, and it's good to know that you've got an inside track. We may need it now. Dr.
The
Jeff,
inside track is only that's the only reason I would rely on Novartis. He actually worked for the company before Novartis bought it.
he worked for Advanced
Advanced, yeah.
Accelerator Applications, eh?
Yes, yeah.
Okay, yeah, we know them too. So,
He is
Dr.
not
Jeff,
happy not happy with Novartis, I'll tell you that.
yeah,
These days.
I know that. Well, the lady who's now in charge of patient relations actually came from Advanced Accelerator Applications as well, Rachel Levine, and we love her. She's really great. But yes, I get it. Let me just, before we finish, go back to Dr. Jeff because I think we have to give him the floor to respond to Dr. Alfredo. Anything you want to say?
He's 100% right. And the problem is doctors are severely overworked and they know what they know. They often don't expand that horizon. Uh, I get my abiraterone from CVS Specialty. I'm asked by CVS Specialty pharmacists all the time, every time, do you have any questions? Do you want to know anything about drug interaction? They ask me. So, so every one of us who gets medication gets it from a pharmacy. And pharmacists are very willing and very knowledgeable about drug interactions. So I support relying on the pharmacist because that's what they do. I've lost a lot of confidence in my colleagues in terms of, as you heard, in terms of how thorough they are and how much out of the way they go. So we have to be our own advocates. We can all go to drugs.com, punch in our drugs, see what the interactions are, and use the pharmacists who are very willing to be helpful to us.
I just want to second the motion on leaning on pharmacists. in my experience, 97% of the pharmacists I've interacted with in my career are eager to be helpful
Yes,
in the way that Jeff describes. Of
absolutely.
course, I'm expecting that the pharmacists at MD Anderson, at Sloan Kettering, are very sophisticated about the questions we've been asking here today. But I want to also caution, if you go to a kind of, I don't think there is such a thing as an average pharmacist, but I think if you go to the average pharmacist and say, why don't you want, do you want to learn about these things? That they will enthusiastically say yes. They'll say, what are you taking? Let me read about it. Let me get back to you. I've never met more than one or two pharmacists who don't want to learn and extend their own knowledge. So I would really encourage people to do that. Jeff, you agree?
Yeah, definitely. But
Thanks,
most of the
guys.
drugs that we're on are not distributed by the corner drugstore.
Right.
You know, they're distributed by specialty pharmacies, and this is really what they do. And so they're very bright. A lot of them are PhDs that you speak to. They're very bright, and as you said, they're very willing to learn and very willing. Most of them already know it. I've been impressed with the level of knowledge these pharmacists have, these PharmDs have, and I rely on them.
Thank you, guys. Len?
Yes, I'm going to wrap it up, Rick, because
Okay.
my lingering COVID is, closing my eyes here.
Okay.
So, guys, thank you very much for a great session. Lots of great contributions, and we'll see you next week.
Thank
Good
you,
night.
Lynn.
And don't
Thank
forget,
Thank
you.
you.
Christopher Columbus
Good
was
night,
not an Italian.
everybody.
All right.